Good afternoon, everyone. Welcome to Research Conference. I hope everyone had a wonderful break. We're so excited to see you back here. Today we have two speakers. Our first speaker is Dr. Danny Laskowitz, who is Vice Chair and Professor of Neurology, Neurobiology, and Anesthesiology here at Duke. He's also the Director of Neuroscience Medicine here at the DCRI. His research focuses on the genetic influences on neuroinflammatory responses and recovery from brain injury. He's been involved with multiple translational trials evaluating new therapies and diagnostics in stroke and acute brain injury, and also focuses on the use of biomarkers to investigate cellular mechanisms of post-traumatic neurodegeneration. We will also be hearing from Dr. Luke James, who's Associate Professor of Anesthesiology and Neurology here at Duke as well. He is Associate Director of the Brain Injury Translational Research Center, and his research interest is in translational and clinical research aspects of intracerebral hemorrhage. He served as the PI on several clinical trials involving patients with ICH and the Duke site PI for multiple large multi-center trials funded by the NIH. Please join me in welcoming our speakers. I think we're going to start with Danny.
Yeah.
Okay, great.
So for full disclosure, I'm not really going to talk about neurogenetics because frankly, I wouldn't even come to myself here to talk about neurogenetics. What I am going to talk about is neuroscience medicine and what we hope to do in the near future with neuroscience medicine. And specifically, neuroscience medicine is a huge area. It obviously encompasses psychiatry and neurology, different cultures, different types of trial. I'm going to talk specifically about translational neuroscience, and by that I mean trials that we're either engaged in doing or hope to do in the near future that might fundamentally change how we take care of patients. I should disclose that one of the drugs I'm going to talk about is a drug that we developed in my lab about 20 years ago that got spun off to a company called AGCN. Okay, so let me just give a bit of personal perspective. I came to Duke in 1995, and it's been a frustrating 20 years to be a neurologist. From my perspective, it looks like our field really has not advanced nearly as far as other areas of medicine. Certainly in perspective, we do have areas of success. So when I was a medical student, there was no treatment for stroke, period. So I was a medical student here at Duke, and the bottom line is you would get called in for a stroke patient, and it would be in the non-acute side of the ER. The ER would be divided into acute and non-acute, and you'd be tripping over the EKG labs of everybody with atypical chest pain and people running around, and you'd go into a back dim room where there might be a young person with a devastating stroke, with a hemispheric stroke that was hemiplegic. There was no rush, there was no one around them, because there was just a therapeutic milieu of nihilism. There's nothing we could do anyway, so you'd come in and make the diagnosis. Clearly that changed with TPA, even though there's a long way to go. So we have made some success in stroke, but we have a long way to go. Clearly in MS, there was no treatment for MS when I started practicing, period. So, and I think I'm dating myself for the clinicians here, I don't know, the longitudinal optic neuritis study had just come out, and we realized what we knew all along, that if you give steroids, it makes things better for a few weeks, but it doesn't change the disease course. It has no fundamental impact on how you do with MS. And of course, now there's so many treatments for MS that the landscape is so littered that it's confusing, even for a clinician, to figure out the nuances, but there's a lot of disease-modifying treatments. Similarly, for mechanical and endovascular devices, at the time, you had a subarachnoid hemorrhage and there was no alternative but to have Alan Friedman at this institution do an open craniotomy. And if you were sick, they couldn't do it because you were too sick. Now every patient gets essentially intervened upon because they have non-invasive interventional techniques. And obviously the endovascular stroke therapies have been the most recent innovation to improve stroke care. Having said that, if you had told me 20 years ago that we still don't have a treatment for Alzheimer's disease, for Parkinson's disease, that we still can't prevent seizures or have a disease-modifying treatment for seizures, I would have said that was crazy. In 20 years, we don't have a single drug for any of these conditions, neurodegenerative conditions, and it's only going to get more acute, certainly as our population ages. So I'm a neurointensivist. I spend most of my time in the neuro ICU and stroke. And particularly in our field, there's been huge frustration in the lack of new therapies. One, neuroprotection. So again, when I started in the 1990s, neuroprotection was right around the corner. We were beginning to understand glutamate excitotoxicity. There were new drugs being developed. That's why I went into stroke and neuro ICU, because I felt in the next 10, 20 years there'd be a renaissance. We'd have new treatments. That obviously hasn't evolved. Neuroplasticity and cell-based intervention. So stem cell therapy, drugs to increase plasticity, these were all supposed to be right around the corner. They have huge promise. None of that promise to date really has been realized, in part because of inadequate clinical trials. So these are areas that I'm going to talk specifically about and what the role of the DCRI might be. So the first question is it true? I mean, certainly from my perspective, it seems like maybe advances in neuroscience have been much slower than the rest of the hospital, but I went out and directly addressed this issue. This is data from Tufts Center for Clinical Drug Development. And what you could see is that if you do a trial in CNS, it's about 18 to 20% longer than any other trial you can do. So here what you see in purple is the clinical development phase. This is when you hand the FDA an IND and say, we're ready to go into people. We already have the preclinical toxicology data. And in the lime green, you can see the new drug registration. That is, how long it actually takes to get a drug approved. And if you look at neurology versus ID or perioperative anesthesiology or antiviral therapies, it takes about twice as long to get a drug approved. These are difficult trials. And just because you take longer and it's more expensive to do a trial, in no way assures that the trial will be successful. So here we look at success rate, and you can see the success rate for new neurologic drugs is 8%. It's a third of what it is in infectious disease or even in oncology. I mean, traditionally very difficult disease areas. So it takes longer, there's a lower failure rate and a higher failure rate. And even here, when you look at cardiovascular, and it looks about comparable, there's a lot more drugs, right? So even though the percentage is only slightly higher than neurology, there's still a lot more drugs approved. And this is what it leads to. If you look at the last 13 years in the CNS, it's about half the number of approvals of any other major disease state. In an area where, arguably, from my perspective, we need new drugs more than any other area, we're just not producing them. And I think even more concerning, if you look at the priority rating, so the FDA will earmark specific drugs that they think have a specific therapeutic advantage with a priority score to help expedite, as opposed to Me Too drugs. And if you look at the priority rating of CNS drugs, it's less than half all other drugs. So not only are there fewer approvals, even the approvals that are being made are in general derivative or maybe incremental benefit, very few novel drugs that really make a difference. So this is somewhat appalling from my perspective. I'll give an example. So migraine is very common, probably the people in the room with migraine. When I started practicing, Imitrex first came out, sumatriptan. Then a whole family of triptans came out that were kind of derivative and maybe slightly different therapeutic indices. The most recent drug for migraine, which came out 8 years ago, was Imitrex with aspirin, or Imitrex with naproxen sodium, that Glaxo marketed as a new drug combination, and that's the type of approval that very often is being made. These are not really groundbreaking approvals. So I'm going to talk specifically about the role that the DCRI can play in addressing this. And from my perspective, and part of the reason I wanted to adopt a leadership role in neuroscience is I think we are uniquely positioned to play a role. I'm going to talk about 3 different trials that we're doing that address the 3 major problems that I talked about earlier in terms of stem cell therapy and plasticity and neuroprotection. And normally when we think about translational research, we're thinking about, preclinical, the traditional bench to bed top, or the cliches that we all use. These trials span the spectrum of early phase to later phase drug delivery. So the first is stem cell therapy. And again, stem cell therapy has got to be one of the big disappointments, certainly in neurology. We've heard about it for decades. It's just never realized its potential. I'll tell you again, from a personal perspective, I've had patients. There was a young woman who had a big spinal cord AVM who was not getting better fast enough, who went to China with cash in hand and went to a stem cell clinic. And this is all too common, that these are unregulated. She met with other people with different neurologic injuries, meningitis or ALS, and they all just received unregulated. She couldn't even tell me what she got, but as long as you had the cash, they'll do it. This doesn't really advance the science. I mean, this is kind of exploitative medicine. So what Renuron did is wanted to actually do this in a rigorous way. So what they have is embryonic fetal stem cells. These are neuroepithelial cells, and they inject them stereotactically. So in the OR, they make a stereotactic implantation into brain parenchyma in patients who had previously had stroke to enhance plasticity. And they actually have data. They have a trial called Pisces 1 where they did this to 13 patients. It wasn't powered for efficacy, but it certainly seems safe. So they wanted to do this trial with us, or they wanted someone to help them do this trial. We're still in the late stage bidding phase, but hopefully this will come to us. The problem with it is that this is a really, really difficult trial to do for a lot of reasons. This is my first attempt at animation. So the challenge is, first of all, protocol development. There's never been a drug that's ever received FDA approval. What should the endpoint be? How do you power it? How do you even get the patients enrolled? The patient enrollment is a huge issue because this is maybe 3 months to a year out after the initial stroke. These patients are not inpatient. You can't capture them. Often they don't even get physical therapy. Their insurance has run out, so it's not like they're making regular PT visits. How do you capture them? They're not easily accessible to the medical system. And once you do capture them, how do you do the neurosurgical standardization. This is invasive brain stereotactic surgery. You don't just want a one-off at hospitals that kind of do this for the protocol. You really want to get them to high-volume centers. So the way this was addressed was actually a brainchild of Brad Coles, who's one of the neurologists, one of my colleagues in the ICU. And this is a web portal. And the idea is that these patients are not in the healthcare system very often. They're hard to identify, but they are very motivated. As a stroke neurologist, and I dare say as neurologists or just physicians in general, we're constantly getting calls from patients saying, hey, are there any therapies? You know, I have this deficit and I hear stem cells may make a difference. So this is a very highly motivated patient population. And what we do is have them identify themselves. So through traditional Google ads and through social media, they will identify themselves and they screen themselves. So we basically ask them many of the enrollment questions, including their level of disability. And once they screen and enroll themselves, all that data comes to the DCRI via the web portal. And what we can do, here you see superimposed the demographics of stroke, which are obviously not evenly distributed. Most stroke is in the north, in the southeast, right in the middle of the stroke belt. So we have pre-made PT spokes that they'll be referred to for formal enrollment. And we have a few hubs that are strategically located. These hubs do the stereotactic neurosurgery, and they're high volume stereotactic neurosurgery hubs. The beauty of this is you can kind of do an adaptive site enrollment. That is, when there are hotspots of people who self-identify in different areas of the country, you could set up spokes for them rather than what we traditionally do. We say, well, enrollment's bad, let's just set up more and more sites and we'll kind of hope for the best. This type of study does not scale that way. So I think this is the type of study that we'd bring value added. I'll tell you, quintiles can't do this study. And the other beautiful thing about this study is we assembled really smart people from different areas. We have Jody Haas, who's a neurologist with specialty in neurorehab to look at the endpoints. We have Laura Jewell, who's an occupational therapist who's an academic, who's done these type of academic trials. We bring in Nandan Ladd, who's a stereotactic neurosurgeon who actually knows the sites that can do all this, in addition to the traditional regulatory and statistical resources. So this is the type of thing that we should be doing. And I would, and obviously I have a bias, but I would venture to say that if we don't do this, I'm not sure anyone else will do this type of study well. Okay, let's move on to another type of study that we're doing. This is an electronic intervention. Again, this isn't just an area of unrealized promise. For those who listen to NPR, or maybe other stations, I don't know, Fox News, they may have, but probably not, you know. So you might have heard about Lumosity, you know, brain games, and there's all these kind of vague assertions that this will forestall Alzheimer's disease, it'll make you smarter, it'll delay cognitive aging. I guess one of the problems is that, although that may well be the case, it kind of makes sense, you can't just make vague assertions, as Lumosity learned when the Federal Trade Commission slapped them with a $2 million fine last January. And so that's deceptive advertising. You can't, without any data, say we're going to treat a disease or forestall Alzheimer's disease. So this really raised the bar to the next level. This may well work, like stem cell therapy, but how do you do a rigorous trial that goes to the FDA, that's approved, actually demonstrate you're doing what you say you're going to do, and then bring it to the broader patient community? This is a really well-performed study that was performed in Nature in 2013. And what this was a video game. And so one task was driving, right? A traditional video game, you had to keep the car from crashing and centered in the middle of the road. One task was sign only. There'd be kind of a red dot, and when you saw the red dot, you had to follow the command underneath it. And then there was a multitask where you had to try to drive and read the signs at the same time. And as you might expect, when you multitask, when you're doing these two different tasks that require attention at the same time, your performance drops off. And that drop off of performance when you multitask is called the cost. How much do you screw up one task when you combine it with several tasks? And like many charts of this type, as one gets older, it's a little bit depressing. On the left, you could see age on the x-axis and performance on the y-axis, and there's kind of this linear relationship. This, on the y-axis, is the multitasking cost, how much worse you get when you're asked to do the two different tasks simultaneously. And this is adaptive. So if you're old and slow, the video game gets just hard enough so that you have 80% accuracy. This does not represent your baseline. It represents how much worse you get from your baseline when you're asked to do two things at once. And you can see it's really this straight line down. In your 60s or 70s, you're like 70% worse. In your 20s, you're like 20, 30% worse. But the amazing thing here is that when patients, older patients, between 68 and 80, these are patients in their 7th, 8th, and 9th decade of life, were taught this task. So they did this 3 times a week for an hour a time, and they were asked to do the multitasking. At 1 month out, you could see this enormous increase in their performance. That's the dotted blue line. So the dotted green line shows that if you just teach them the one task, not multitasking, they get better. There's a practice effect. But 6 months out, they retain the ability to multitask. 6 months out after no practice, they're actually better than the 20 and 30-year-olds who did it naively. So, this raises an aging population. It's certainly appealing to me as I get older. Can you reverse the effects of aging? One of the really cool things about this study is that, A, it was performed very rigorously, and there was a biomarker. And what you see here is quantitative EEG, this midline theta. There's actually an EEG correlate of being able to effectively multitask. And they showed that it transcended specific cognitive tests. So it's working memory, and it seemed to make you better across different cognitive tests of attention span, working memory, retention. So this is compelling, and this was the basis of a study that they started called EVO. This is an electronic video game. And it was this study, which actually is being led by Scott Collins, who's not here but has been heroically leading the study because there's been a lot of challenges, is the first, to my knowledge, to look at this type of electronic intervention in a rigorous way to go to the FDA and say, yes, we have an intervention that's as rigorous as a pharmacological intervention. And what this is a video game that children the age of 8 to 12 play just 55 minutes a day for 5 days, and they want to play it. It's like this adaptive, cool video game. It's immersive. And the idea is that once it's approved, there's, by the way, a strict randomized clinical trial with a placebo, and this is one of the issues that we worked with the FDA to get what would be a rigorous placebo control. In this case, it's a word game that presumably is as addictive but doesn't teach the multitasking. I've never played this, but I hear it's compelling. If you play, I'd be interested in playing it. It's fun, actually. It's something that kids want to do. And the idea is that once the FDA approves it, it'll be doctor prescribed, insurance reimbursed. This would be a legit, not Lumosity where you see it on the back of like a Delta thing, the magazine that you play with, but a real medical intervention that it's a subscription model, it's mobile, and actually there's a centralized portal. So that is the physician knows how compliant you are, they can actually look at your treatment effects and individualize it. So this is a really big deal, I think, and I think this sets the stage for future devices of its type. So again, this is the type of innovative type of therapy that hopefully we would see more of. Now again, I'll take a step back, and I'm going to stop within 5-10 minutes to give to you, but I'll take a step back. I came in 1995. My training is in neuro-ICU. I do a lot of my clinical work in the neurointensive care unit, and when I came in 95, we had very little to offer patients. They have a traumatic brain injury, often young people, and a lot of what I did was provide supportive care. You keep them alive, and you tell parents very often horrible choices. Do you want to let your child die? Do you want to get a tracheostomy and a gastrostomy, and perhaps they'd be in a nursing home? They may never regain a quality of life. Just awful. It was very depressing. And you might ask, why the hell did you go into that field? Because it's very awful. And the reason is because if you had asked me when I was interviewing for neurology residency, I would say it's going to be totally different in 10 to 20 years, right? In my lifetime, we're going to see a change like the first cancer chemotherapy. Yes, what we're doing now is crazy, that they do actually bedside, I don't know if people are aware of this, but this is actually what we do in the ICU. It's a bedside ventriculostomy where the neurosurgeon will take like a hand drill blindly and like drill through the skull, and they'll blindly put a plastic catheter into the brain until they see CSF squirt back. That's the level of sophistication. It sounds bad, but that's what we do in the ICU. And I would say, of course it won't be like that in 20 years. This is archaic. 20 years later, it's exactly the same thing. It's more expensive. We've got even more beeping devices. We measure everything. We do near-infrared spectroscopy, and we do brain parenchymal oximetry, and all these. We have nothing to offer patients. We don't have a single therapeutic that's been shown to improve outcome, period. So yes, there's a lot of beeping devices, and we provide supportive care. A lot of what I do on a daily basis is talk to parents about, do you want your child to go to a nursing home at the age of 21, or do you want to withdraw care? It actually has not changed. So for me, this is a labor of love. We need a new neuroprotective agent. We need a neuroprotective agent. One thing we learned early on is that although we don't have a neuroprotective agent, what we do have is this clear clinical insight that patients don't always do the same way. In other words, a lot of what we do is we prognosticate. But I can tell you that you could take two 20-year-old kids with a traumatic brain injury who got into a car accident on Irwin Road, and they could be the same age, they can have the same radiographic findings, they could have the same neurologic presentation. One may walk out of the ICU, and one might have horrible brain swelling, cerebral edema, herniate, and die in front of us. So clearly we're wired differently to respond to injury. So one one gene that seems to play a huge role is this ApoE, apolipoprotein E. And it's ironic because we pigeonholed apolipoprotein E for its role in lipoprotein metabolism. It's a constituent of VLDL and HDL and plays a role in cholesterol metabolism. But independent of that, it seems to play a role in neurologic disease. It's made in the brain, upregulated after injury, and plays a role in neurologic disease. There are 3 common isoforms which differ by a single amino acid. So this is not a rare mutation that causes an abnormal gene product that causes a disease. These are common human polymorphisms. That is, the E3, which is most common, is 78%. The E4 is 14%. It's 14%. So there's a lot of people in this room who have the E4 allele. This is not a rare familial mutation. And it turns out that if you have the E4 allele, not only do you get Alzheimer's disease at an earlier age, you do worse after these diverse forms of brain injury, intracranial hemorrhage, traumatic brain injury, subarachnoid hemorrhage. So we asked, why is this the case? Why is a protein that we've really pigeonholed in the context of cholesterol metabolism playing such a fundamentally important role in how you do after brain injury? And it turns out that ApoE has a receptor binding region on one of these alpha helices, and this receptor binding region, we think, binds a specific receptor on microglia, on the endogenous brain immune cells, to downregulate inflammatory responses. So that was the idea, because if that's true, that's common for Alzheimer's disease and every form of acute brain injury. So we like to pigeonhole different diseases, but the reality is glial activation is central to all those forms of both acute and chronic brain injury. So what we did is we put the traditional linear conception of drug development on its head. So normally the way this works is you'll have a basic scientist, and he'll have a very specific pathway, and he'll say, wow, this threonine on this intracellular tail is phosphorylated and causes a second messenger signaling. I'm going to target this and have a very sophisticated, reductionistic targeted therapy. And then from there, I'm going to get a lead candidate, and I'm going to do preclinical testing to show efficacy in my animal models. And from there, I'm going to put it right to people, show it's safe, and go right to a phase 2 and a phase 3 trial. The problem with this is it often doesn't work. So you might be a brilliant scientist and have a great reductionistic idea of exactly which threonine you're going to not phosphorylate, but there's all these homeostatic mechanisms in cells, right? So there's a lot of redundancy built in. You could block one pathway and another pathway will take its place. It's why, it used to be a joke 20 years ago that when the first transgenic mice were made, we'd knock out a gene, but there's no phenotype. They kind of look normal. And that's one problem. One problem is that the preclinical, the animal models were just wrong, right? They didn't make sense. You can't do a diffuse axonal injury model in a mouse that doesn't perhaps have much white matter, or they're just conducted badly. When the first neuroprotection trials came out with glutamate antagonists, they didn't take into account that the animals got cold. They were hypothermic, which was neuroprotective. So they were confounded. And even when you have maybe an animal model that makes sense, often it fails to translate to phase 3. In neurology, we see this all the time. Phase 2 trials look promising, but they're small and they're underpowered, and there's no translation to phase 3. Everyone gets very excited. At one point for stroke, AstraZeneca, the drug reps actually came and said, okay, we're expecting a positive result. How will we use this? And of course, in New England Journal of Medicine, this was NXY059, the same trial. They came out and said, oh, I guess this failed also. Never mind. So a lot of drug companies are not even pursuing this anymore. So we decided to turn this on its head. So we took a protein that we knew was important, because the gene product seemed to be influencing outcome, and went back to say, can we make that druggable? So first we said, there's all these studies, but they're really, they're crappy studies, they're bad studies. So you can take like 50 or 100 patients or 70 patients and say E4 is associated with bad outcome. That's not a proper genetic study, it's underpowered. So if you're a lawyer, you say the preponderance of the data suggests it. So the first thing we did is we went to animals, and we took animals in which the E4 transgene was inserted. The mouse ApoE was knocked out, and the E4, the E3 transgene was inserted. We put it through all these animal models in our lab, and the E4 animals did worse. So this kind of bore out what we were seeing clinically. E4 was associated with worse outcome, even in a homogeneous, reproducible animal model. We next said, okay, you can't take the whole ApoE, right? It's too big, but you could take this receptor binding region, you can linearize it, and you could create a druggable target that crosses into the brain. So this was the CN105. We found that it reduced inflammation in vitro. We put it into our animal models and showed that it reduced inflammation. And here we decided at this point, it's really important in drug development to think, what is your eventual clinical outlet going to be? And that's just not where might it work best, but what's most doable. And here we decided intracranial hemorrhage, because intracranial hemorrhage is kind of more of a tractable clinical trial to do. You have patients that are sequestered often in the ICU. It's more of a homogeneous injury as opposed to TBI, where patients come in kind of drunk with all kinds of non-cranial injuries. And this was done in Luke's lab, and I'm going to turn this over to him in a few slides. And what it's showing is that you can inject Clostridial collagenase and recreate an intracranial hemorrhage that looks very much like a human intracranial hemorrhage. If you give drug, it doesn't make the hemorrhage any bigger or smaller, but it does change outcome. It reduces edema. Here we're looking at rotor rod latency, which is basically how long a mouse can run on a rod. And you can see the treated animals do significantly better than the untreated animals. And we also look at cognitive deficits, because after a significant traumatic brain injury, everybody has a cognitive deficit. Even when they go back to the work they had before, when you ask them, they say, I don't learn, I don't retain, I read slower. So what we try to do is look at clinically relevant endpoints. So this is cognitive deficit after 30 days. And again, you can see that animals that are untreated, it's the same. These are animals that don't learn. They're thrown in a pool of opacified water, and they have to find where the submerged platform is. Mice are kind of like cats that you might throw in a bathtub. They actually can swim, they don't like to, so it's a huge reward to be able to sit on the platform. A normal animal will use the visual spatial cues and learn where that platform is, and they'll get there faster and faster. An animal after TBI can't learn. Every day is like a new day. You throw them in and the latency is the same. So here you can see the treated animals got significantly better, and we also reduced histologically evidence of microglial activation. These are the CNS immune cells. I'm going to now turn it over to Luke. What I will say is that the DCRI enabled me to go from a lab to a phase 1 trial. So Bruce Burnett from DCRI came to us, sat with us at the FDA meeting, and we were able to get a pre-IND meeting. We were able to get our IND. We were able to get orphan drug status for intracranial hemorrhage. Jeff Guptill took it the next step into a phase 1 study, a single escalating and multiple escalating dose study. So this is huge for kind of an academic lab to go from an animal model to people. That was done successfully here. We arrived at an optimal dosing, which is 1 milligram a kilogram, Q6 hours for 3 days. And actually the CN-105 exhibited linearity. That is, you have to start at a very low dose that the FDA tells you have to start, basically, because it's safe. And as you go up, you hope to get linear dosing, which we did. So based on that, we've moved to a phase 2 study, and now we're working with Luke, who has a great deal of expertise in ICH. So, let me get this to you.
All right, thanks. Thanks. Yes, all right. All right, great. So thanks, Danny. That's excellent. I've only been around for the latter half of the ApoE peptide story, but the entirety of the story of it in intracerebral hemorrhage, which is where we find ourselves today. And there was a lot of thought that went into which avenue of brain injury, whether acute or chronic, or what type of stroke to pursue. But first, I want to set a little bit of the background for the disease entity that we went after. And I guess before that, I'll tell you a little bit about myself. I trained here at Duke in neurology and anesthesiology, and then went into the neuro ICU. I'm not quite as old as Danny, so I'm not quite as nihilistic about how the patients do. And the things that I've seen change, not that we have more therapies, but we have better access to care, and ICU care has come a long way in 12 years. So we get more patients that come in, and we save more of them. Now, if you want to say that's a worse outcome than death, all right, well, that's arguable potentially, but at least more of them make it out of the hospital. So this is disease we were going after, and it is a chronic disease of, is there a pointer on this? Maybe not. So small vessels in the brain, the perforating vessels that come off the large arteries, get injured by chronic injury from diabetes or hypertension. And then at some point, something causes them to rupture, and then you have bleeding in very pathognomonic places in the brain. All bleeding in the brain is not the same, and that's another thing that we've learned in the last 12 years. And what we're going after is primary hypertensive intracerebral hemorrhage. So this chronic disease that sets up these small perforated vessels to rupture and causes these areas of hemorrhage. And why we're going after that is because it represents only a relatively small subset of stroke in its entirety in the U.S. There's about 1 million-ish, 1.25 million strokes per year in the U.S. There's about 150 to 200,000 ICH per year in the U.S. But you can see the proportion of patients that do worse when you compare it to ischemic stroke are far, far higher. So much more of them die, much more of them are debilitated if they live. And there's no therapeutic intervention. In stroke, there's TPA, there's now thrombectomy. They're looking at ways to pair thrombectomy with other interventions, other medications to improve outcomes for stroke. So, taking even a further step back, when we look at hemorrhage, we know certain things about a patient or a way a patient presents will predict that patient's outcome. In fact, the clinical scale, the ICH score that was developed by Claude Hemphill in San Francisco 2002 or 2003 has about an 80% predictive value in now out to 24 months after ICH. So these clinical indicators very strongly predicted outcome once you take the nihilistic nature of clinicians out of it. If you survive all patients, then these things do quite well. If the clinicians believe the patient's going to do poorly, the patient's going to do poorly despite what these things may or may not say. So we do know that the hemorrhage volume, the larger the volume, the less likely the patient is to do favorably. The presentation Glasgow coma score, which really in a lot of ways is a measure of level of consciousness. So the more severe the injury, the lower the level of consciousness, the less favorably the patient does long term. The presence of interventricular hemorrhage. So for those of you that don't see a lot of CT scans, these are the ventricles. They should not have blood in them. They should be filled with CSF. When blood gets into the ventricular space, you're talking about a whole different beast. The phenotype of that patient behaves very, very differently than the patient that doesn't have blood in those ventricles. And if they have blood in the ventricles, the presence, it correlates with unfavorable outcome. Age, obviously. The older you are, the less ability you have to recover after any kind of brain injury. Location. The challenge here is that location has a lot to do with what is important in terms of neuroanatomy and neurofunction that's near the bleed. So if the bleed occurs next to an area of brain that is important for some sort of function, obviously your outcome is going to be worse. And then this sort of idea that cerebral edema and inflammation plays a role. And it's been largely hard to quantify until the last 2 or 3 years from a volumetric imaging standpoint. We've now got some collaborators in Yale and MGH that have really figured this out for us. And so now we have at least ways to quantify and measure the impact of this lesser understood entity of edema and inflammation after hemorrhage. So those are the predictors, and along those lines, the mechanisms of injury that occur after blood is in the parenchyma of the brain. It's not a static event, so this idea of early hematoma growth, which is really subsumed like the last nearly decade of clinical research in ICH, the bleeding occurs and then it expands, usually over the course of about 4 to 6 hours, but up to about 24 hours afterwards, until it becomes a final volume of blood within the brain. Then you have the occurrence of edema, so the brain doesn't like the blood. It gets inflamed because the blood is there, and then the blood starts to get broken down, and when it breaks down into heme and heme byproducts, which cause reactive oxygen species to occur, and then you have this whole inflammatory cascade that occurs, and at some point that inflammatory cascade begins to shift into recovery mechanisms, and we do understand now that you can't completely shut down inflammation because then there's no recovery. And so it's this interplay between, the inflammatory substrates that cause the inflammation, the inflammatory cascades that are then caused by the substrates, and then how the brain modulates the shift from acute inflammation into the recovery phase. So I took the modifiable risk factors. I didn't tell you about coagulopathy, but there is a coagulopathy-associated bleed, so patients are set up for bleeding. They are coagulopathic. They come in, they bleed. If you reverse the coagulopathy, they do better. That's quite well understood. With the development of the novel oral anticoagulants, we now have some research that needs to be done in this area. but that has been understood for decades and really hasn't been an area where anybody's been asking questions. Hemorrhage volume and hemorrhage evolution, though, have been. There's such a strong correlation between how a hemorrhage evolves and what its final volume is with outcome that everything, for the most part, has been focused on reducing the amount of hemorrhage in the brain or reducing the amount at which it extends. And then blood pressure plays into that. It was quite well correlated that the longer someone's blood pressure is elevated after they've had a hemorrhage, the more their hemorrhage is likely to evolve and the worse outcome they have. And then where we focused in the lab and now in the clinic is on the secondary injury mechanisms and inflammation-associated edema. So I just want to run through the major clinical trials in ICH over the past few years. I apologize, it's very small. When I started in training, or right after training, they had just finished the FAST trial. So we had the recombinant factor VII that could very rapidly reverse coagulopathy. They decided to use it in all comers for hemorrhage. So anytime somebody had a brain hemorrhage, they would give recombinant factor VII, very clearly decrease the size of the hemorrhage. So the hemorrhages for folks that got factor VII were much, much smaller, but the outcomes were absolutely no different. At the time, they thought this was because there was a higher incidence of DVT, PE, and cardiac ischemia from use of recombinant factor VII in patients that might be at risk for thrombotic complications. I'm going to submit to you that there might be something on top of that as well after I get through the next few slides. So this was the patient populations that made up both the factor VII and non-factor VII placebo groups. They used two different drug dosages, and these were the outcome data looking at survival curves. There was also no functional benefit. The patients didn't do better neurologically if they survived. At the same time that they were doing the FAST trial, they were coming out with Stitch 2. Stitch 1, these were surgical intervention trials, so you would do open craniotomies in patients that had intracerebral hemorrhage. You would take out the hemorrhage, and you'd see. Stitch 1 was basically anybody with a hemorrhage that a surgeon thought they could get to. They took the hemorrhage out, and they looked at outcomes, and the patients did no better, but they thought that in people that were slightly younger and their hemorrhage was closer to the cortex of the brain, these patients might be a subpopulation that would benefit from a surgical intervention and hematoma evacuation. So that's what Stitch 2 was. It was based on that subpopulation analysis from Stitch 1, and it turns out there is no benefit there either to early surgery or conservative treatment. Now, I often get questions that, well, the p-values are very close, they're 0.075, but these were appropriately powered second study off of a primary study. So not only did they pick the population they thought would benefit, they had adequate data to power that trial and still couldn't find a statistically significant difference. So more recently, they moved into blood pressure as a way to decrease hemorrhage volume. It's been known for many years while they were doing the FAST trial and the Stitch trials that you could reduce the higher the blood pressure and the longer the blood pressure was elevated, the more hemorrhage evolved and the greater the subsequent volume of the hemorrhage. They tied it to outcome, so they knew that the long-term outcomes in patients that remained hypertensive after hemorrhage were worse. So they did two trials. They did the INTERACT trial, which was a Australian-Chinese patient population, and they did an American-based population, the ATTACK trial, which is in a couple of slides. And they demonstrated here that if you reduced blood pressure, so they demonstrated a couple things. One is that you could acutely reduce blood pressure in 6 hours after hemorrhage, which had never been done before. We'd never enrolled these patients in that kind of an acute trial before. So that was very exciting. You could get to these patients, you could intervene on them, you could do something to them. We thought it was helpful, but it turns out it actually wasn't, because there was no population that benefited at all from the intensive treatment to reduce the blood pressure to within the normal range. And while there was some benefit in some of their secondary outcomes with quality of life, their primary outcomes saw no benefit, no statistically significant differences either. And similarly, in the ATTACK data, the American population, which they actually ended early because they were not going to fail to meet their outcome measures when their DSMB met a couple of years ago, They couldn't find any shift in the modified Rankin score. So the modified Rankin score is a 0 to 6 score. 0 is no deficits whatsoever, 6 is dead, and what they're looking for is whether they can take patients in the unfavorable range, the 3 to 5 range, and shift them into the 0 to 2 range so that they have more favorable quality of life outcome metrics. So the reason I'll submit that the antihypertensive therapies didn't work and that the hemorrhage evolution therapies didn't work is because there's something more than just making the hemorrhage, taking the hemorrhage out and making the hemorrhage volume less. The idea that the hemorrhage occurs and it is so acute even as it evolves, because it evolves over the first couple hours, that the damage of the blood being there has been done. So really the focus on hemorrhage volume and hemorrhage evolution has been, in retrospect, mildly misplaced. It is important to limit the amount of hemorrhage that occurs because at some point it's irreparable and the patients proceed on to brain death. But beyond that, the importance of secondary injury mechanisms and edema haven't really been appreciated as much. So, and this sort of highlights that. These are the current clinical trials in ICH, and it really, you get to about here. These are the ones that are currently ongoing. And you have to get to about halfway down, and none of these are NIH funded. So this is the only NIH funded trial that's looking at inflammatory mechanisms. This is a defuroxamine study. It's an iron chelator. And even though they're looking at inflammatory mechanisms of reducing reactive oxygen species by iron chelation, the way they propositioned it to the NIH was they were going to reduce the hemorrhage volume in the first 3 days by taking the iron and the blood products out of the brain through the chelator. So everything else is still looking at hemorrhage volume reduction, which I think we've beat, if not a dead horse, a very nearly dead horse. So we'll see where they go. So what we in the lab did, and what through Danny's really thought leadership, is the idea that we can't do just one thing. One mechanism's not going to solve this problem. There's so many things going on in the brain at the time of injury with inflammatory cascades, et cetera, that we really need a multimodal therapy. Now, this is from 1998, and the idea was that they might tool together multiple agents, but ApoE kind of does that for us, because ApoE does a lot of stuff. It's very pleiotropic. We focused on microglial modulation, but in fact works in receptor sites in neurons, systemic cells, and a lot of different places and a lot of different mechanisms within each cell population. So it's a very pleiotropic cell. It does represent a multimodal therapy. This is a slide just to represent that we focused on microglial modulation because we were interested in inflammation, and microglia are the cornerstone of inflammation in the brain. And so much of the work we did in the lab revolved around how different things, and ApoE in particular, affected microglial cells. That's me. I always put this in there because I look how young I am. I still have a lot of hope and aspirations. That's when I started in the lab. I hadn't been at Duke for training and have now been on faculty for about almost 12 years, and my kids are old. I think I blame my kids mostly for making me look a lot older than I am now. This is our model. So this is the mouse. This is the microneedle. The ventilator sitting over there. There's an anesthetic canister somewhere back there. The stereotactic frame. You basically drill a little burr hole. The drill is over on this arm. Drill a little burr hole in the mouse head. You put the needle in. You inject anything you want. We've injected blood. We've injected Clostridial collagenase. The Clostridial collagenase breaks down the base membrane of the vessels, and then the animals spontaneously rupture. I like that model because the hemorrhage evolves over a period of hours after initial injection, whereas the autologous blood model, the blood stays there. It is there. It's the same volume from the time you put it in to to hours, days later. So I want to hammer home how this was backward translation of a phenomenon we found in humans. So this is our work from our Duke cohort. Others have done much, much better, more decisive work, especially the folks at Cincinnati. But we found that basically the presence of an ApoE4 allele in a population of intracerebral hemorrhage patients quite correlated with unfavorable outcome by modified Rankin score as well as a Glasgow outcome score. And what we found is that it didn't necessarily correlate as well with hemorrhage volume as it did with the amount of edema that was generated. And so that's that's where this sort of tied in and why we went into the mouse model. Our first step was demonstrating that the mice that had humanized ApoE backgrounds performed in the same way. And since we control the amount of hemorrhage volume that we have, we can look at the different genetic backgrounds, and it is not a function of hemorrhage volume, it's a function of background, it's a function of inflammation that occurs because of the genetic background. These are rotorods and neuroseverity scores that are worse in ApoE4 animals. And then as Danny alluded to, he developed a peptide based on the ApoE holoprotein, and we demonstrated that these are wild type 3s and 4s, ApoE3 and ApoE4 animals, and this is rotorod scoring. And we demonstrated that based on the genetic background, the humanized ApoE background of the mouse, they had differing effects of the therapeutic agent. So there was a pharmacogenomic effect of the drug. And then we did even more work. I'm not going to show you everything we did. We worked on this for 6 or 8 years. But there's actually a sex-specific pharmacogenomic effect. And so you have male animals here and female animals here. And these are ApoE4s and 4 females and 3 females. And based on whether the animal was a male or a female animal, and based on their ApoE background, they performed differently with the effects of the peptide. Now, I should say this is a slightly different peptide than the one we've moved into humans in the last couple of years. The one we've moved into humans has a separate set of animal work that's done that I'm not going to present to you today. This is just the idea of using ApoE mimetic peptides. So there were a number of hurdles. We had to cross each one of them, and basically this is a testament to Danny's intestinal fortitude, that regardless of what happened to him and this idea of ApoE, he just kept plugging away until we're about to put this into humans in a disease state and look for clinical, signs of clinical efficacy, which is a real strong testament to him. So this is the trial, the CATCH trial. It is a very long name of the proof of concept study, but essentially what we're looking at is a multi-center trial. It's going to be 3 to 4 sites within the region, so up to UVA and possibly down to Atlanta and Charlotte. Phase 2A trial with CN-105, dosing within the first 12 hours after supratentorial intracerebral hemorrhage. So we're not going to look at folks that have hemorrhages in their cerebellum or in their brainstem, but in their cerebral hemispheres, and we're going to get the drug into them as quickly as we possibly can. This is a phase 2 trial, so obviously the primary objective is to assess safety, but then obviously secondary objectives are to assess mortality and functional outcomes. And I'm going to blow through the last few slides here because I know we're trying to wrap up. This is where it gets interesting to me, because wherever all these other trials, as they lead into their phase 3 study, they've really looked at hematoma volume and hematoma evolution and maybe some effect on edema. But we haven't been able to really quantify edema as well as we'd like until the last couple of years. So this is really the first study that can look at how a therapeutic intervention affects the mechanisms of choice. So we're not really that interested in hematoma volume and expansion, other than to say we're going to measure it and make sure it doesn't get worse. But what we're really interested in is how edema evolves and what is the effect of our intervention on edema, and what is the best modality to measure the edema, whether it's CT or MRI, in terms of moving into a phase 3 trial, as that is our primary point of intervention. And then, of course, Danny's other hat has been to look at biomarkers, especially of neuroinflammation after brain injury. So we're going to utilize a lot of the assays and things that he's helped develop and things that we've found in the model that either are upregulated or downregulated in terms of inflammatory proteins, and we're going to measure them in the patients in this phase 2 trial. So here are our endpoints. We have safety endpoints, we have clinical outcome endpoints, where modified Rankin is sort of the gold standard for stroke work. It's not the greatest gold standard, but it's the one we have. It's the most validated. It's the 0 to 6 scale that I told you about before. We're also going to use a bunch of other ones, the United Stroke Scale score, the Glasgow Coma score, measures of cognition with the MoCA. The Barthel Index is largely a measure of activities of daily living, and then the stroke scores. And then, of course, our secondary endpoints have to do with imaging and biochemical biomarkers. And these are, just to throw them out there, these are the ones we measured in the model and in human subjects in some of our smaller Duke cohort work that led up to this. So I don't care if you read any of this. I just threw this up there. There seems to me there's two ways to do early phase 2 trials. One is to capture as many subjects as you can in a heterogeneous patient population and try and ferret out which population you should take to the next phase 2 trial or into phase 3. And the other way is the way we're going, because the cohort that is available to us is somewhat small, and it would take forever to enroll hundreds or 1,000 ICH patients within the first 12 hours. It'd be prohibitively expensive. So we are going after a very, what we can do to make a homogeneous patient population for this early phase 2 trial. This is the study design. So the patient gets an ICH, they come in, they get diagnosed by CT. We get to them or their LAR in the first 12 hours. They're evaluated by eligibility, they're consented, they get their first treatment within the first 12 hours from onset, and they get a dose every 6 hours for up to a maximum of 13 doses or 3 days worth of dosing. And then we follow them out to discharge and then out to 60 days with an in-person interview at 30 days and a telephone interview at 60 days. This is a very feasible design. There won't be any problems with study execution. And so I'm going to end on this slide because I think this is really what's most interesting to me as an academic. It's not. It is the idea that we've created this study to really gauge what our exploratory analysis are going to be and what we can take into a later phase 2 trial as a measure of our clinical efficacy that will set up then a phase 3. This idea that, well, first of all, we have to measure pharmacokinetics in the disease state. So we'll have several patients from our Duke cohort that will get very frequent blood draws to make sure that the pharmacokinetics in ICH match the pharmacokinetics and the normal controls that were done through Guptill and the DCRU. We have to measure hematoma expansion. It's almost the industry standard, so to ignore that completely would be a mistake. But the focus, again, is on looking at volumetric assessments of edema and then biological markers that tie into edema generation with inflammation in the periphery. And that is all I have. Thank you very much for your time and attention. Do we take questions?
Time for maybe one or two.
Dance?
How did you guys determine the 12-hour window?
So some of it's feasibility,
Yeah.
and some of it's, a lot of it's mechanism of the agent. So the idea that the hemorrhage evolves over the first 6 hours, and intervening as early as possible seems reasonable because the inflammatory cascades are starting as soon as the hemorrhage occurs in the brain. But the feasibility of getting to patients within the first few hours is very challenging in enrolling them into a study. And the idea from the preclinical work that there is a therapeutic window that might stretch out as far as 12 hours. So the study is, I didn't go into too much detail of the phase 2 study, but it is designed to try and push the latency from ictus to drug infusion as quickly as possible. So that we'll get some feel of whether 12 hours is actually a real window or whether it needs to be much shorter as you move to the next phase.
And how many of the people that you plan to enroll, how many do you think will come from outside hospitals? Because I know you guys get a lot of transfers.
So,
and do you think that will impact, how will that impact the study?
So you mean as a referral into the so that's an excellent question. I think that's going to affect a lot of the enrollment here at Duke. That won't affect the enrollment at UVA or Carolinas and Charlotte because they are not, their catchment is such that their ICH come in primarily through them. Wake Forest is somewhere in between. That's part of the reason the 12-hour window was designed. It is feasible for us to capture patients within that 12-hour window and get to their LAR for enrollment here. But there are, as evidenced by the Interact and Attach trials, there are networks of hospitals that can get to patients in their LARs within a few hours after ICH.
But it raises some interesting questions about tele-enrollment also. So we now have telestroke, right? And you're making face-to-face contact as interactive. Can you enroll remotely? Because that would hugely facilitate the study.
Yeah, it's interesting.
I think you're going to see that, well, I guess I have a bias there. I hope you're going to see that evolve over the next couple of years. So while this phase 2A trial is a little early for the tele-enrollment, 3 years from now when it's completed and we have those data and we're starting to move forward with the next trial, it might not be. It might be a lot more mature.
Because you can't do it by phone. I don't believe you can do it by phone, or they have to sign in person anyway, but you may be able to pre-consent with their LAR via video.
In 3 years, there may not be any signatures. I mean, maybe we're scanning retinas to get enrollments, right? I mean, there's a lot that's rapidly changing. Thank you.
Thank you.